Thank you very much, Dr. Deepankar Das, and it's a pleasure to be part of this symposium. And I'm so delighted to see that we have, apart from both you and Dr. JB, we have true blue pathologists also attending. I'm a pseudo-pathologist, as Soumya knows. Can you please put up my presentation? So I thought I'll restrict to, except for one slide on what we are supposed to see in immune-mediated scleritis, Deepankar, I thought I'll restrict to infectious, because Soumya didn't send me the slides for immune-mediated. I'm lying. No, because we don't have, so in other words, for immune-mediated, we don't really take too many biopsies. So I went through my library of cases and I couldn't really see a case where I'd sent for a biopsy, but it turned out to be purely immune-mediated. So that's why, apart from a slight discussion, I'm going to go to infectious, which is very interesting also. I'm sure Dr. JB will be interested to see the pathology in these diseases. So, Clinico pathological of infectious, mostly scleritis, which is case-based. Very quickly, this is what I wanted to say about pathology in scleritis. So, we know that pathology in scleritis is actually infrequently employed. Unlike, say, for me, it's corneal tissue. You really need the histopathology to figure out what's happening. And many other aspects of the eye, we need pathology. So, however, in the scleral tissue, it's because how much can we biopsy? So we take very small fragments of tissue and then we expect the pathologist to do some miracle from it and bring out the diagnosis. That is kind of hard. And then most of the cases of scleritis can be either an isolated immune-mediated disorder or they can be associated with systemic autoimmune disease. If it's systemic autoimmune disease, sometimes the answer is in front of us. So say RA or GPA and so on. So we don't really look at pathology from sclera. So the most important role for me as a clinician when I want to perform a scleral biopsy is when I have conditions which mimic immune-mediated scleritis, for example, infection, and the rarer neoplasm as well. And second is, even though I know it's infectious scleritis, but oftentimes we know that we have to take multiple scrapings from microbiology in order to get to the diagnosis. And this is the second very important role of pathology, where it can help us because pathology can pick up, say, fungal filaments very easily, even from scleral tissues. So it's always a confusion whether our scleritis is autoimmune or a masquerade or infection. The pathology in scleritis has been classified in an earlier paper by Professor Narsingh Rao and his group, where they had taken the autopsies of over 50 eyeballs of patients who had enucleation done for scleritis, and then they looked at it. And then the other group wrote a review on it, which I'm quoting here. And they divided pathology in scleritis as either systemic immune-mediated, in which case, if you see the sclera under the microscope, you're likely to see varying mixtures of palisading granulomas, necrosis, and vasculitis. Whereas in the case of infection, you're going to see obviously a lot of acute inflammation and sort of devastating necrosis in the tissues. And in the case of an idiopathic immune-mediated scleritis, they have mentioned that you will be more likely to see chronic non-specific inflammation with either follicles and various amount of fibrosis because it's very chronic condition in these cases. So that is what you're likely to see in the pathology of scleritis. Coming straight away to the case-based part of my talk, my first case is a 55-year-old man. He had injury while chopping wood, and when he came to us, we couldn't. You could see in the slides here. You can see that he has a very diffuse, angry-looking eye, and somewhere here is a nodule. Not very sure. So what we did is, and he had secondary glaucoma. The B scan showed shallow choroidals. So while we had to explore to see where exactly is a penetrating injury, and we took microbiological scrapings, very soon on follow-up, the patient then started developing necrosis in this area actually, and not in the what we thought was a nodule inferiorly. The first microbiology culture was doubtful, but it came as Corynebacterium. We started the patient on antibiotics. Patient is just not improving. And subsequently, we saw that the patient then presented with abscess-like looking, like a draining sinus-like lesion here, which on a subsequent, the antibiotics are still continued, subsequent visit it worsened. And at this point, when we took material from here, luckily for us, this was the third scraping that both the microbiology showed fungal filaments, and by this time we got more sort of smart, and we sent a lot of tissue to the pathology clinic department as well, and they could isolate this nice big fat fungal filaments which are happily growing in there. So luckily, once we got the diagnosis of fungus from microbiology and pathology, we could start the patient on antifungals, and we had a remarkable resolution for this patient. The second case I have is slightly different scleritis, where you have scleritis with uveitis, and even the cornea was involved. So this was like a sclerokeratouveitis. The main focus is this nodule sitting, straddling the limbus, as well as going over to the cornea. In fact, the peripheral cornea had thinned out so much that there was a communication from the anterior chamber into this nodule, and the pupil, if you are able to see, is slightly peaked for that reason. So this obviously was looking very not at all like immune mediated. This is not a look at the surrounding tissue, doesn't even look that angry. So for us, the top diagnosis we had was infection. And if we examine the patient systemically, we could see that he had depressed nasal bridge, he had thickened ear pinna as well, and this very dry appearance. He also had some trophic ulcers. So this was, we were dealing with a patient with Hansen's, and since we also had to repair the tissue because it was communicating with the anterior chamber, so we had planned for excision biopsy with a patch graft. This is what the patient underwent, and what you can see is this chronic inflammation. And when we go to the special stains, he was teeming with Mycobacterium leprae in that nodule. Patient also had slit skin biopsy from the skin, the ear pinna, and that also showed leprae bacilli, and the patient was started on Hansen's treatment, but he kept on defaulting to the treatment and ultimately was lost to follow-up. The third case I had to discuss is a case of, this is very interesting case, presented as what we thought was necrotizing scleritis with PUK. This is a young male patient, and our top diagnosis for necrotizing scleritis with peripheral ulcerative keratitis was sort of a systemic vasculitis, especially GPA. So we investigated the patient more than once. We did all the serological tests, ANCA, 2-3 times, maybe sent the patient to rheumatologist. The patient had also undergone excision biopsy a couple of times, in which the only report was non-specific inflammatory cells. So this is not the first visit pictures, but the pictures when he came, when he already had perforation because of the chronic PUK. And so we have blinders. When we look at scleritis, we think it's only scleritis. But what now we see in retrospect is that this area looks very white, actually, and there's some kind of plaque here. So those are the clues. And there was a nodular component as well to that area of peripheral thinning and the white plaques over here. So the patient was on high dose of steroids, whether it's topical, oral, and also immunomodulators, but nothing would improve the patient. Finally, the PUK just kept on progressing, and this is the nodule, which now looks like a very dense white plaque. And by this time, we knew we were dealing with something else, and the oncology colleagues stepped in. By this time, they knew that we are not at all dealing with scleritis, and the only option for this patient was evisceration. During evisceration, in fact, there was extensive bleeding, and the choroid was firmly adherent to the sclera. And so the final diagnosis, based on histopathology, I need not take any guesses also, is that this was a case of invasive OSS, and you can see that such proliferation of the tissues. So if this is the coats of the sclera, so the OSSN was invading deep into the eye, as well as these squamous pearls that you see typical, as well as a lot of inflammation even along the uvea. So in the earlier part of the disease, that the patient did have a lot of inflammation, which kind of put us off track. But the keratic plaques, as the patient kept on falling up, was the final clue. So this is too late to resuscitate the patient. This is in a nutshell what we saw for the patient. Coming to another case of quote-unquote necrotizing scleritis. By this time, all of you non-pathologists also have realized that we're not on the track of necrotizing. 56-year-old man, 3 months history, and drop-in vision comes to us, and already came with investigations as well as microbiology workup, because there was these nodules which looked like yellowish and more than one. So the top diagnosis was infectious scleritis for this patient, and one of the nodules also underwent biopsy, which no organisms came from that. And we thought that this bare area is where partly the biopsy was done. And the patient had been receiving antibiotics as well as oral steroids, and there was no improvement. So by the time we saw the patient, we also couldn't figure out, because the clinical picture was masked. And the first thing, one of us went ahead and repeated the scleral biopsy, which showed a lot of chronic inflammation. Maybe the amount of tissue was not representative, or Oz was very small. So as the patient followed up, the same story, that the patient didn't improve at all. Maybe 2 or 3 weeks later, we saw this picture where that area where we took the biopsy from was very quickly getting extensively fibrosed, and not looking healthy. Once again, our oncology colleagues were also seeing the case with us, and they diagnosed the patient to have a sort of a nodular ulcerative variant of OSSN. And the CT scan, you can see that there is thickening. It's involving the coat of the eye from that side, and therefore this patient also had to undergo exenteration. And you can see this beautiful specimen, well, beautiful for us, but not for the patient or anyone else, where the tumor had invaded into the coats of the eye as well, so causing compression. So this was a diffuse OSSN with orbital invasion, and the patient had to undergo exenteration. Coming to probably my last case is a case of scleritis with granulomatous uveitis. Whenever we have a patient with granulomatous uveitis along with scleritis, then it's different from the routine infection also. We know that there's a high chance of infection if you see, say, hypopyon and very prolific anterior segment inflammation. So for me, I've always felt that these cases represent very severe or very chronic inflammation. So this patient did not give any history of trauma, and by the time he presented to us, he had secondary glaucoma. So we did an AC tab and scleral biopsy. I don't have the initial pictures, but pretty much post biopsy, this is what the patient looked like with that. So the histopathology actually revealed gram variable bacilli, which are acid fast and beaded. This was like tissues that showed chronic inflammation with epithelioid and giant cells, and we could also isolate more bacilli. So finally, the diagnosis was atypical mycobacterium. Unfortunately, this patient did not have a great outcome, had extension of the infection despite our best efforts.
Somasheila,
So
can
that's
you
it
conclude?
in a nutshell. And this is our new team at Shantilal Sangvi, where Dr. Dipankar was so kind to introduce, and these are my colleagues who work with me. So we see scleritis as an infection. Everybody else scratches their brains, but I am the gleam in my eye. Hopefully the patient doesn't see that, but I get very happy when I see those cases, and it's so satisfying to treat them thanks to microbiology and histopathology. Thank you very much, Dipankar.
Great and challenging cases, Somasheila. Just a quick question, whether you see infection sometimes in the tumor OSSN or a combination of immunologic versus infections, can you see in a combined way?
Yes, the second one definitely, because we have, even Dr. JB sir has published, so we have patients with chronic RA presenting to us with initially with, say, necrotizing scleritis, and that gets secondarily infected. And that has not happened once, but I've seen more than maybe 5 to 6 such patients. And the second is infection on tumor, though I have not seen a patient with us. Luckily, the tumor missed as scleritis is very, very rare. So these are the only 2 cases in my career that we were co-managing. But the other side, the other entity of getting an infection secondary on immune-mediated, I think that will happen, and we have to keep looking out for those cases.